Everyone, welcome back to the second half of the Nurses Parallel Forum. Next speaking, we've got Matt, who is one of the consultants here at Addenbrooke's, and he is also the co-lead on the hepatocellular MDT. And Matt is going to be talking to you today about what's new in HCC. Thanks, Matt.
Okay, well, thank you, Fiona. Can you hear me okay?
Yes, we can hear you, thank you.
Lovely, good. Okay, so really what I wanted to do today was to not give you a sort of straight up talk about HCC, because I'm sure that you've probably had that at some point in the last sort of 3 or 4 years. What I really wanted to do is to sort of flag up sort of 3 or 4 things which are new or are likely to be coming around in the sphere of liver cancer in the near future. And so what I wanted to do is to talk about the sort of changing patient demographic that we've got, some changes in investigations that we use, patient fitness. That's not new, but obviously it's something actually I want to try and reiterate, and then come on to the changes which we've got coming up in terms of patient management. So thinking first about the changing patients that we've got now. Many of you will know that liver cancer is a big problem, but if you speak to the sort of wider medical community, most of them don't really know that liver is somewhere between the 2nd and 3rd biggest cause of cancer-related death worldwide. And so you see from this data here that liver cancer sees off about 800,000 people per year. And the reason why that sounds like a very large number is that most of them are not in this country. So what we know is that the bulk of deaths worldwide is in East Asia, predominantly driven by hepatitis B, and in Africa, again, predominantly driven by undiagnosed hepatitis B. But the world is changing. And one of the things that we are seeing is that around here, and this is data from America, and it's similar story in Western Europe as it is in the UK, as it is in the US, that what we are seeing is that cancer demographics are changing, and that many of the cancers which have long caused an awful lot of death, such as colorectal and breast, because of our ability now to treat these cancers far, far more effectively, is that cancer death rates are actually going down in these cancers. Whereas the cancers which we're seeing increasing death rates are things like pancreas and in liver disease. And actually in the States, primary liver cancer is forecast to become the 3rd biggest cause of cancer-related death by 2030. Now, why is this? Well, I suspect for you lot, you wouldn't be surprised to learn that the patient demographics are changing, and changing quite quickly. So this is the NHANES cohorts. This is a big American study on tens of thousands of patients. And what they do is they measure simple demographics and simple blood analytes over the course of sort of 30 years. And what you can see over the course of 30 years is that there are a number of things which are going in the right direction. So you see of this sort of cohort of just under 60,000 patients, the rates of people who are misusing alcohol has gone down from 4% down to 2.8%, that the rates of smoking have tumbled by 10 whole percent over the course of 25, 30 years. And the rates of hepatitis C, due to safe injecting practice and also due to effective treatments, have nearly halved. So these are all positive things which are going on in terms of risk factors for both liver disease and liver cancer. But the things which are going in the wrong direction are, as I suspect you would know, are the rates of obesity. So going from 1 in 5 to nearly 1 in 2.5 over the course of 30 years. Rates of type 2 diabetes nearly doubling, and the rate of NAFLD going from 1 in 5 to nearly 1 in 3. So what you're seeing is a real change in global sort of patient demographics, and that's really going to impact on the kind of people we are going to see in clinic, and particularly when you're starting to think about HCC, because the kind of liver patients that we see and are going to come across our clinics really affect what the pattern of HCC that we're going to see. So this is a slightly complicated slide, but I'll talk you through it slowly. So if you look at an individual basis, so if an individual with liver disease has one of these diseases, so hepatitis C or hepatitis B, alcohol, or the euphemistically called metabolic disorders, that's actually NAFLD, and you ask the question, what is the risk of this particular patient getting HCC as compared to someone who's healthy? What you can see is the overwhelming highest risk is having hepatitis C. So if you have hepatitis C, your chance of getting HCC is around 60 times a normal person. If you've got NAFLD, your chances of getting HCC are only about 3 times. So in an individual patient, it becomes very, very obvious as to who should undergo screening if they have liver disease. So obviously patients with hepatitis C, obviously hepatitis B, obviously alcohol, but who on earth should we be screening who has NAFLD? If you look at it the other way around, rather than on an individual patient basis, but you look at what comes across my clinic, and so this is the global HCC population. So if you take all of them and then ask the question, okay, well, what is the risk factor which gave me this bunch of patients? What you see is that the dominant population risk factor is now NAFLD. And that's because that although the risk associated with NAFLD is relatively low, the numbers of patients that we've got are so overwhelmingly large that most HCCs are now coming from NAFLD. And then this obviously is this discrepancy between these two facts, which makes this very, very difficult to screen for. Obviously, if you've got a cohort of patients who've got hepatitis C, you just screen, that's very simple. If you've got a vast numbers of patients with NAFLD, we just simply don't have the resources, the time, or the ultrasonographers in order to try and screen all of these patients. Now, not only are we seeing a change in the risk demographic, we're also seeing a change in the location of where these people are coming from. So this is Public Health England data, an incredibly interesting report. Now, what we're looking at here is the geographical location of where patients come from. Now, I recognize that these are two slightly different measures. So this is patients who are admitted with alcohol-related problems, where do they live? And then this is rates of obesity, where do they live? So it's a slightly different measure, but what you see is that these maps are completely different. So if you look at our neck of the woods, what you see is that where do patients live who have alcohol-related emissions? Well, obviously you see high rates in Norwich, very high rates in Luton, decent rates in Cambridgeshire and up into Peterborough. So you see that this is predominantly urban populations which have very, very high rates of alcohol-specific emissions. If you look at the adult rates of obesity, what you can see is that this is a completely different map. What you see is that the highest rates of obesity are around the Wash, Lincolnshire coast, down into Great Yarmouth, and then the Essex coast. So what we're going to see over the next 15, 20 years is not only a different bunch of patients with different diseases, we're actually going to find that they're coming from completely different places. And so what we need to be doing is thinking about trying to hoover these patients up. And so in Cambridge, we have the access surgery, which serves our local homeless population. This just isn't going to work for these people who have very high rates of NAFLD. These are living in underserved communities on our coasts, which are pretty far away from most of our hospitals. So thinking about investigation now for HCC. So as I suspect that most of you know, the HCC is a disease that we diagnose non-invasively, and radiologists are your friends in this fight. So what we need to be doing is to be doing the right scan. And if you want to know whether a patient has HCC within their liver, you need to get a 3 or even better, a 4-phase scan of their liver. It doesn't matter whether it's a CT or MR, in order to demonstrate arterial phase hyperenhancement, AFI, and portal venous phase washout. So this is what we're talking about. So here we go. So this is arterial phase hyperenhancement, or AFI, so increased contrast within the lesion as compared to the background. And then in the later phase, in the portal phase, you've got portal venous phase washout. So if you are not doing these kind of scans, you will not diagnose HCC. Similarly, that we get an awful lot of referrals from various places and we only get to see a portal venous phase scan. This is inadequate, and we will just send it straight back and say, do a 3 or 4 phase scan. So please, when you're thinking about trying to diagnose HCC, know the type of scan that you want to do and make sure that your local hospital is doing it. Now, one of the things which we have really suffered from in the last sort of 15 to 20 years has been a lack of standardization with our reporting and our communication of what our level of concern is about patients' lesions within their liver. And that this has been hugely helped by the deployment of the LIRAD system. Now, some of you will know about this, some of you will not. Now, this is something which we now use routinely in Addenbrooke's for reporting all lesions within livers. And so I thought it would be useful just to go over what the schema does and what it doesn't do. So the important thing is that we can only report on LIRAD's observations. They're not lesions, they're observations, number one, in a patient who either has cirrhosis, so got radiological evidence of cirrhosis, or chronic viral hepatitis, so hepatitis B or C. So if they've got cirrhosis or viral hepatitis, we can then start talking about lesions within their liver. And then what we're then doing is we're then starting to think about what our level of concern is radiologically about the lesions within their liver. And the system goes from 1 to 5 with increasing concern about HCC. If they are a LIRADS 5 lesion, we are saying that this is definitely an HCC and that we're going to do something about it, hopefully. If it's a 1, we are not concerned and they don't need any further follow-up. And then with increasing stages between those two, you've got increasing likelihood of this being an HCC. You've then got these extra ones. So LIRADS M mean that we think it's malignant, but we don't think it's necessarily an HCC. So this could be a cholangiocarcinoma, it could be a MET. LIRADS NC means that this is non-characterizable. Okay, so this is a technically inadequate scan. Either you haven't done enough phases or the patient's breathed through different sequences. And then there's LRTIV, which is tumor in vein, which is highly suggestive, almost pathognomonic of HCC. So if you have large caliber vascular invasion within the liver, LRTIV basically means HCC. And then how do we determine which stage within the LIRAD scoring system people are at? Well, what we do is we base it on AFI, the size of the lesion, and then other features. So as you can see on the previous scan, this was a 25 millimeter lesion with AFI, okay? So greater than 20 millimeters AFI, and it had washout. So it had a one extra major feature. So this would be a LIRADS 5 HCC. And then similarly, we have other features like an encapsule or threshold growth. And people have now done retrospective analysis based on this scoring system to look at what the probability is that if we say it's LIRADS 5, that it is then an HCC on either biopsy or resection. And what you see is that LIRADS 5, 96% of these turn out to be HCC. But LIRADS 4 are the ones which are really, really tricky, because we're saying that we are sort of 70% sold that this is an HCC, but we're not completely there. And so therefore, this is the basis for what we are now doing, such that if it's a LIRADS 5, we then get on and just crack on and treat them. If it's a LIRADS 4, we generally try and biopsy these lesions in order to absolutely confirm that this is an HCC or not. Similarly, if it's a 3, if it's indeterminate but a lower probability, we generally recommend interval imaging down the line. So that's the LIRAD system. You will see it on stuff that we report back from the MDT, and you will see it on radiological reports going forward. So the next thing that I want to touch on is patient fitness. So this encompasses both their liver function, but also their performance status. And it's really, this is incredibly crucial. So everyone assumes that their management is going to be determined by their tumor configuration. It's not at all. The first question we ask in the clinic and in the MDT is, what's their liver function? The second question we ask is, what's their performance status? So this is why it's really, really, really crucial that from you guys in the referring centers that you tell us, okay, what their liver function is now and whether they have ever had a previous decompensation event, because that tells me that their liver function is not that brilliant, even if, you know, the bilirubin and the PT are normal. So this is why these two are sort of first up in terms of our management strategy. And this is based on loads and loads of data from many years ago. And this is one study. It's quite old now, but it's from Hanover. And what they did was that they just took nearly 400 patients. They didn't worry about what they were treating them with, whether they were transplanting them or resecting. All they did was they asked from the point of referral, if we measure their liver function at point of referral, and then we can do whatever we want, resect, transplant, anything, and then just follow them forward. And what you can see is that if you've got either no cirrhosis or Child-Pugh A, your outcome looks like this. But by the time you get into Child-Pugh B or even Child-Pugh C, okay, the chances of even making 6 months with HCC is significantly lower. So this is why we need to know, because these patients are likely going to go on and die of liver failure, not necessarily of their HCC. And importantly, it's pretty much a rule that if a patient has ascites or encephalopathy, or they are beyond Child-Pugh B7, they have no treatment options other than consideration of transplant. So it's really, really important that if you have a patient with any of these, that you calibrate their and their family's expectations before you send them up, so that we can't treat their tumor if they're in liver failure at the same time. The second thing is the performance status. Now, this is something which is really, really misunderstood by a number of people. The system that we tend to use is the Eastern Cooperative Oncology Group, the ECOG performance status. Now, if you have a chance, find this on the internet, print it out, and put it either in your clinic room or in your office, because the number of referrals that we get are, from 85, 90-year-olds, and they put performance status 0. Okay, this tells me that someone either doesn't understand what performance status is or hasn't seen the patient. Because let's read it. Okay, so someone who has a performance status of 0 is fully active. They are able to carry out all pre-disease performance without restriction. Okay, so that means that they are able to work, and that they are able to care for themselves, and they are able to carry out a job. If you start looking at 1, that they are slightly restricted, but able to carry out work of a light or sedentary nature, so they're able to self-care, they're able to do housework, could you look at this patient and say to yourself, they could work in my office doing what I do? Because that's pretty much what we do. We sit at computers all day and have a chat with people and walk around and request stuff. We do kind of office work style stuff. So is your patient looking like that? Because if you start thinking about down here, so performance status of 3, capable of carrying out only limited self-care, confined to bed or chair more than 50% of waking hours. So if you imagine walking around a geriatric ward and seeing a cohort of patients who are medically fit for discharge and awaiting a care package at home, okay, they are by definition performance status 3. And this becomes important because all of the evidence that we have for treating HCC is based on patients from clinical trials who have a performance status of 0 or 1. We have no evidence whatsoever and no license to treat patients who have a performance status of 3. So again, if you have patients who have, who are down here, they have carers, or they don't care for themselves in some way, they are probably performance status 3, and their chances of getting some kind of anti-tumoral treatment is very low. And the basis for that is this. So this is a bigger trial. This is from Korea now. Same kind of design. You just take all HCCs referred at this time point here, and then it doesn't matter what you've done to them, resect, transplant, nothing. You just follow them forward, and you base it on their performance status at the time of referral. And what you can see is if you've got performance status of 0, so if you're still in full-time employment, it doesn't matter what you do to these patients, 50% survival at nearly 4 years. Whereas if you've got a performance status of 3, okay, which is down here, so this is the patient who's sitting on the Jerry's ward, waiting to go home, dressed, but sitting in a chair, okay, their chances of making 12 months with an HCC is low. So this is why performance status is far, far, far more important than tumor configuration. And so that is why we really, really want to know this detail when we talk about these patients in the MDT. So lastly, what I want to do is to come on to patient management, because there have been some significant changes here. Most of you will be aware of the BCLC algorithms. There's the Barcelona Clinic liver cancer algorithm. Yes, I completely get that this is, if you're not in the HCC game, this can be a little bit baffling. But what I want to do is just to break it down for you. So first thing to do is, if a patient has HCC, the first question, as you can see, that we ask, because the BCLC algorithm asks it, is not what the tumor configuration is. The first question you're going to ask yourself is, what's the performance status and what's the liver function? So you can see that you're asking here for a performance status of 0 and Charles-Pugh A. Here, 0 to 2 and Charles-Pugh A to B. If you have a performance status of greater than 2, so your patient who's sitting there quite happily waiting for their care package on the geriatric ward, in the EASL guidelines, they are straight to best supportive care. Now, we don't necessarily do this, but I'm saying that this is what international guidelines would suggest that we should be doing. Then once you have determined the liver function and the performance status, then and only then do you start asking questions about the tumor configuration. Now, this is where it starts becoming a bit baffling to people who don't use this terribly often, but I'll break it down for you. So what you have to do is just think about it in terms of how many tumors that they have got and how many they have and where are they. So that if you've got a small tumor out in the districts, which is not involving blood vessels, you've got a whole load of different options that we can potentially treat this tumor with. Now, obviously, we're going to be aiming for a curative option, so RFA, resection or transplant, if we can. But obviously, if you've got someone who's more frail or has medical comorbidities that would prevent us considering a resection or transplant, then we may be starting to look at TAE. As soon as the tumor starts to get bigger or starts invading structures like the portal vein, or it starts becoming bilobar, your options for dealing with these start to narrow. And that's why we have to try and get the best scan that we can in order to determine exactly how many tumors they've got, exactly where they are, and what the relationship to the blood vessels is. So if I was giving this talk, say 3 years ago, and we were going to be talking about what new things were likely to be coming along in the near future, one of the things that I probably have talked about would have been CERT, and where its place within this management algorithm was going to sit. Now, over the last 3 years, we've now had several multi-center randomized controlled trials comparing CERT with systemic therapy, and there was great hopes for CERT, but unfortunately, all of these trials were negative. And so at the moment, the place of CERT is rather uncertain. It's probably going to be trialed against TACE, but it's automatically going to be at a disadvantage. So the tariff cost to the NHS of TACE is about 1,200 quid. The tariff cost to the NHS of CERT is over £25,000. So, you're going to have to get an awful lot of benefit from CERT in a head-to-head with TACE in order to change practice. Where I think things are actually going to be changing in the next 12 to 18 months are novel agents. Now, these have again been trialed head-to-head with sorafenib in advanced stage HCC, and that the trials have come out actually positive. Now, what do we do at the moment? So if you have someone who is heading for systemic therapy, they don't actually come and see me, they come and see my colleague, Dr. Bristi Basu in oncology. And in general, the first line treatment is either sorafenib, which is the more established treatment, or the newer lenvatinib. And this is our data from Cambridge, and what you can see is that for all the patients that we treat with sorafenib, we're getting about a 50% survival at about 13 months. So not bad, but not brilliant. And then if they progress on sorafenib, that they can then go on to have these other agents. What's new is this randomized controlled trial here, and this reported earlier in the year, and this is rumbling through regulatory approval at the moment and is likely to supplant sorafenib in the near future. So atezolizumab and bevacizumab. Atezolizumab modulates the PD-1 pathway, which many of you will have heard of great successes in melanoma, and bevacizumab, otherwise known as Avastin, has a track record in breast cancer. So the combination of the two, what you can see here in this Kaplan-Meier curve is this is the sorafenib treated patients. You can see a 50% survival, about 13 months, exactly the same as we're seeing in our patients in Cambridge. But you can see is that if you get atezolizumab and bevacizumab, is that you don't actually get to 50% 5-year survival, that, you know, it's all the way out here at 18 months. So there's an enormous amount of excitement that we're going to be able to significantly benefit these patients with more advanced disease with this combination. The important thing for you guys to know about is, again, standard clinical trial design, that that this is big numbers of patients, pushing 800 in total that were randomized, but performance status on an ECOG scale of either 0 or 1. So these are fit patients, and so the license is likely to be based on fit, healthy patients. The ability to give more sick, more frail patients this kind of combination is not likely to be coming along anytime soon. And similarly, they have to be Child-Pugh A to consider this treatment. Because it seems to have significant survival benefit, one of the things that it may do is, in the longer term, is that it may actually supplant TACE, which we spend an enormous lot of time doing and giving, but actually the level of benefit that we're going to be seeing with atezolizumab and bevacizumab may actually lead to systemic therapy coming rather earlier in the treatment algorithm. And then the final thing, which is coming around, is SABR. Many of you will have heard of that, and again, we don't quite know where that's going to sit within the management algorithm. It could be used to supplant TACE, or it potentially could be used to supplant RFA. But again, at the moment, we're still acquiring trial evidence to decide on where it should go. For those of you who have not heard of it before, this is stereotactic ablative radiotherapy, so very focused, very high dose radiotherapy, which, given the ability to map tumors, allows us to give beam radiotherapy from multiple different directions and give a very, very high dose in one area whilst sparing surrounding areas. Now, what we're finding is that the benefits of our SABR are that it's non-invasive, and so we don't need to give a general anesthetic as we would with radiofrequency ablation, and we don't need to make a hole in people. The difficulty that we've got is that it is less accurate with RFA. Obviously, with RFA, we get to stick a needle straight in the tumor and to kill the tumor from the inside. Now, we've got relatively limited experience with SABR, but hopefully that's going to be changing fairly shortly. Then this is one of the cases. This is one that we actually sent up to Birmingham because they're rather ahead of us in SABR. So this is a man who had a tumor in the inferior right lobe. Here's the arterial phase. You see the arterial phase hyperenhancement here, and then this portal venous phase washout. This is 2 months before SABR. And then he was sent back to us, and we then scanned him afterwards. And what you can see is that this lesion has shrunk down. There might be perhaps a slight rind here of tumor, but in general, the tumor is an awful lot smaller. But what you can also see is that there's this halo of damage to the surrounding liver. So this is what I was meaning by that it may be less specific and less targetable than RFA. And what you can also see is he also had a further tumor higher up in his liver, and you can see that there's further damage to this area of the liver here. So I think RFA and TACE will both still have their places, but I think that SABR will probably sit somewhere in between those two. So key points for what I've said are that our patient demographic is changing, and that is not only in terms of the diseases that they have, but also the location and where they live. We have deployed the LIRAD system, and you will be seeing that now on reports and on feedback from the tumor MDT. Patient factors, please, please, please think about your liver function. Please accurately document your performance status, and please prime patients and their families in order that they don't come along with grossly unrealistic expectations of what we can potentially achieve. Novel therapies are coming along, obviously systemic therapies with Bev/Atezo and also SABR. And I am more than happy to take any questions either now on the chat, or please email me on my nhs.net account. Thank you.
Thanks, Matt. That was really, really interesting and informative. We haven't got any questions on the chat, but I've just got one question. Regarding performance status, I had a patient the other day that we referred to with HCC who had gross ascites. I put his performance status to 0 because he was able to undertake all of his normal activities and was actually still working as a chef with the ascites. What do you think about that decision? Would you have put him as a 0 or a 1?
Well, again, you have to make a decision there about the level of work, and obviously zero to 1 is less important to me. You know, I mean, how physical a job is being a chef? Probably reasonably physical. So therefore, 0 would be reasonable. He's self-caring. That's fine. More tricky is when it's 2 or 3, because the cases where we really struggle are where we get referrals which say 85, performance status 0. Now that's fine. We do see patients, you know, who are still running 10K at 85. That's fine. It's just when we get patients who, you know, I have had patients literally carried into my clinic on a stretcher, and they, you know, the referral has said that they have decent performance status. You know, either patients are, you know, either people are just ticking a box and not giving us the information that we need, because that's not fair in the COVID era to drag them 90 miles across East Anglia just to come and see me and have a, you know, grossly excessive expectation of what we can potentially achieve in someone who's quite frail. And I think it's important to flag up that it's, you know, the TACE, yes, we can give it at performance status 2, but pretty much all of the rest, you know, resection, transplant, RFA, systemic therapy, you know, 2 is pushing it. And so if you have that in your mind, that, you know, a geriatric patient completely dressed, completely well, sitting there on the geriatric ward waiting to go home is performance status 3, okay, because they are not capable of self-care and that they are spending more than 50% of their day in a chair, okay, that is performance status 3, and they are not going to get any treatment whatsoever. Thank
you. Thanks for answering that and clearing that up. Has anybody got any more questions on chat before we let Matt go? If not, we'll move on to the